And we agreed that after these two especially stimulating talks, we would like to open this for discussion among people here. And obviously, most welcome our questions from our audience. So we'll be happy to look at and we'll see whether
There's some in the chat box.
Yeah, let's take a look. Any questions right away? Yeah, I see it.
I did. Not like him. Oh,
These were our comments. Yes. So Sam, let me ask you again, thanking you for your wonderful presentation, and you invigorated everybody around. I wanted to ask you on behalf of our long QT patients and their families, would you recommend that long QT patient in general, I'm not only speaking about ICD patients, could benefit from planned systematic psychological consultation or advice on regular basis, or I would broaden it to generally arrhythmia diseases and inherited. What is your recommendation and approach? And we have clinicians here, Dr. Huang, Dr. Aktas, who may comment from cardiology perspective on the topic, but we'll be happy to hear from you first.
Thanks, Dr. Zareba. Well, look, I think that all patients dealing with heart disease need an annual mental health checkup, frankly. I mean, I think that there's just no way you don't get in a rut from time to time. We all get in ruts. We all get down from watching the news. We all get down from worrying about our planet. We all get down from worrying about how other people treat each other around the world. We all get tired of seeing distress around the world. So I think when you're dealing with your own health threats, you're dealing with a condition like long QT syndrome, where you can't just go down to the corner and grab a book on coping with long QT syndrome. I mean, they don't have that. You can't go down to anywhere and have a group of long QT, hey, let's get together and chat, right? I mean, that isn't going to happen. So that's isolated. That's distressing. It's invalidated. And so I think a mental health checkup once a year makes sense. I think the other thing that makes sense in cardiac visits with cardiology, is there anything I should be thinking about or worrying about? Is there anything I should be avoiding? They'll say no and no. Okay, so that the corollary is, okay, most things I can do and not even think about. Yep. I want to get to where we're limiting the sort of intellectual and emotional burden of living with these diseases. I want our patients to say, yep, I got that condition. Yep, I got that device, but yet I'm going to go live life. And I don't live life, nor does anyone, with zero risk. And that's okay. That's okay. I mean, I think I'm not trying to be Pollyannish. I'm trying to be confrontive. I want to confront that our patients don't simply just waltz out of our offices happy as a go lucky. They do walk out of our offices with some graveness, some gravity of thoughts. And I think the more that we can help them with that and address those, the better off we do. So my number one recommendation is one, annual mental health checkup. Number two is, yeah, I think the more that we could provide structured kinds of, we call it ICD school around here, or coping with heart school, where we just have chances for our patients to come together and talk about what they've been going through.
David, Mehmet, any comments from your perspective, seeing inherited arrhythmia patients who may have anxiety, depression? What's your approach?
Yeah, I think the last two talks raised some very important questions that I think many of us clinicians, especially on the cardiology side, tend to overlook: the emotional, the psychological impact of the diagnosis on these patients and their families. One example that comes to mind, especially for these long QT patients, maybe long QT 1 and 2 patients, is the restriction on their sports participation, and that has implications towards exercise as well. And we see that some patients, while they're very, very compliant, but they also take it to the nth degree so that they actually stop exercises, and which in the long term actually becomes detrimental to their overall health and well-being, both physically and emotionally and psychologically. And so I think balancing a lot of these factors, moderation, exercise and moderation certainly is very okay for our patients, and keeping up good communication with their care providers, I think, would be very important. The stresses of the current medical practice, the visits are getting shorter and shorter, unfortunately. But the last two talks, last two presentations really emphasize a lot of the psychological aspects that we need to keep up with for these patients.
I would just echo the need for a multidisciplinary approach. As clinicians, we may focus on risk stratifying patients, making sure that the medications are prescribed. There's, of course, that's one piece of it, and I think the need to support them in all the different manners is really important. But we try to do that, actually. We have, you all know, this multidisciplinary arrhythmia conference where we review patients where there's situations like restrictions with exercise, should they exercise and how much to restrict. And I think it really requires a multidisciplinary approach to make sure the patients do well.
Agreed. I think it's really important, and I think activity is where the rubber meets the road in terms of medical care, psychological comfort, and ultimately outcome and well-being. So, we just can't simply cheerlead ourselves into feeling less anxious and depressed. At some level, behavior has to back that up. We have to actually be able to test our thoughts and feelings. Otherwise, we're posers, we're false, we're fake. I don't like fake. I like real deal.
That's a great comment. I would like to ask you, Pari, about your contacts with your long QT and other patients and aspects of psychological care. How does it come from your perspective and your experience?
I think as an APP, we're probably more kind of in tune to that because the patients tend to see us more for longer periods of time. We have a different rapport with them as we get to know them over the years, and can make recommendations and hopefully help in that way, but just be more of an emotional support for them. But certainly having a more formalized structure of person that they can go to professionally as well too, definitely is an area that I think we need to kind of integrate more in what we do.
That's good. I see that Mrs. Kostecki wrote a comment about that some Sears looks like you are in demand. So can you read, can you read some of your comment? The comment?
Sure. Can you hear me?
Yeah.
Okay. So I'm saying that I believe your team should offer an online contact to someone like Sam Sears in times of stress for a pick-me-up or to help with mental health issues, or as he refers to it, as a validation for one's feelings or state of mind. I really enjoyed your presentation, Mr. Sears. My sister actually had died of LQTS. She was a 52-year-old. We found out years before that my father had the condition, and we were all offered a part of your program to have blood work, et cetera, sent down to your university. Unfortunately, my sister was the only one out of all my brothers and sisters who did not do the testing. At the time, she was going through a very stressful divorce. She was probably not educated enough to know that she could do it so simply Had she done it, probably would have saved her life. And I think as a family, and you're dealing with it from as basically as an outsider, not knowing at the time that it could have been prevented. I think it would have been nice for her to be able to go to someone like Dr. or Mr. Sears, and maybe she could have been more informed and might have taken that next step. Yeah, so that's my point is one of the patients or family members. Today I'm listening to you and loving it. I absorb information, and I also love to reach out and be authentic, as Mr. Sears has said. So I'll leave that with you.
If I could respond.
So, Sam, could you comment, because Mr. Krohetsky is raising a very important point. What about kind of online or other services? I know that local clinics probably everywhere have some ability, but could you comment on that, please?
Yeah, a couple of things. First off, thanks for your comments. You got some guts to talk about losing somebody you love and showing up for a Saturday to talk about that all afternoon. There's no way to make grief easier, but what doesn't work is avoiding. And so thank you for being able to talk. I'm not sure I could have said the sentences without, choking up. And
Thank you.
Missing your sister and recognizing that we could have helped her. Preventing premature death, and that's what that is. Preventing premature death is what we do. It's what drives us, and preventing that is everything. And whether it's a multidisciplinary team, whether it's each one of us as individuals, I mean, this is our life's work. And so I want no losses. I don't want to lose anybody for this. Now, having said that, I mean, what do? We have no mental health. If you tried to see a psychologist in the greater 29 areas of North Carolina that I live in, there's not a single provider that has any capacity right now, let alone somebody that knows what they're talking about in terms of the complexity of heart disease and some of the issues that we're dealing with. So it is the case that there really aren't enough professionals to do what we need to do. We have to develop teams at a better, faster rate than we are now, and we're just simply not. In fact, here at East Carolina, we are the only place in America that's training psychologists to be ready to manage complex cardiovascular disease. There are other places trying, but we are actually producing them at a regular clip. So we got to have more. As much as I like to lead, I don't think that's enough. So what about this? I think this local, I think you've got to have some local mental health facilities help anytime. You have all patients are dealing with a significant heart disease. So having a local person, even if it's once a year, that to come in and say, hey, it's important for me to check in. Here's how I think things are going. Do you have any suggestions, any recommendations? I mean, it's not that weird. I mean, we've got to get over this mental health stigma. It's not helping anyone. So we've got to overcome that. And obviously part of my bald-headed sergeant discussion, I mean, I look like a damn sergeant. I'm the sergeant of mental health, right? I'm like demanding that our troops find a way to deal with mental health. We can't do this anymore. I'm tough as nails, and I think everybody needs mental health. We need to pay attention to getting through this life as a group of humans. We can do this. I told you I'd rant. I did. See that? That was a great rant. I'm a ranter.
Thank you, Sam.
I love that. May I comment? I love that you rant, but I didn't get an answer to how that can be overcome. How can we have a contact as part of your LQTS family? Is there a name that you can refer or recommend if I'm having one of those days where I really just feel I'm blaming the world for okay, let's say the death of my sister, that was unnecessary, and it does surface often. And,
Yeah.
you know, it's a worry, it's a threat. And so I always feel that, gosh, I wish I could just go online to Mr. So-and-so or Mrs. So-and-so or person X, just to say, today I'm having this day. Can you kind of, you know, what's going on? Is there more research being done? Just keep me informed or whatever. I don't know. I'm just saying that there are those days where you just wish you could just have your that person there at the click of, you know, the online access.
Sure. Well, my bad for not feeling like I answered the question. Specifically, psychologists, psychiatrists are licensed by state. So our ability to practice outside the state is limited by state laws. So my intention about the idea of having a local provider or within your state is what that was a half answer, but that was the answer because I'm not able to practice in Rochester. I don't have a license for the state of New York. And until we have reciprocity across states, you know, that would be fine with me. I could easily find plenty to do around the country. But I only have my licenses in Florida and North Carolina, so I actually cannot practice or can't provide healthcare services outside those states. So any solution would be a fairly difficult one, and not as easy as it seems.
I hear you. And I'm from Canada, actually. I'm not even in the States, so it makes it even that much more difficult.
Well, I love Canada. I wish I could practice up there. I'd come over there. You're in Toronto?
I love Canada too. Thank you. But thank you for all yours. Honestly, I really, all of you, your whole panel, I'm just absorbing this and really appreciating all this information. Thanks.
I wanted to ask Sam and Meng, Meng, demonstrated that patients with long QT with versus without ICD, after adjusting for various conditions, covariates, they do not show really significant changes in their questionnaire and their depression, anxiety, as you showed us. So this is to some extent welcoming news. We understand that all these patients have long QT, so this is different probably denominator. But Sam, was it surprising to you what you hear from Meng?
No. I believe the problem is the disease more than the device.
Yes, Meng.
I would ask Dr. Wang kind of what she thought too about that.
Yeah, I think that's the key message from our study. That's the underlying severity of the disease. The severity of the underlying disease seems to play a more like a bigger role than the device itself.
I do think that the little strand of finding around syncope is important, and it's because syncope and shocks make people feel out of control.
Yes.
And when you feel out of control, you don't forget what that feels like. If you've ever encountered a situation where you felt completely helpless, that is a low point that is hard to forget. And when it's a cardiac one, it's one we got to pay attention to. What I try to do is make our patients tell us about it. Okay, what did you think? What did you feel? What was the situation? What happened beforehand? What happened afterhand? Because that develops a set of phobic responses to it that then carries forward. And so when we can pull some of that down and deconstruct it, often patients won't develop quite the fear that they would have otherwise.
Any other questions here? Bonnie, Becky, and Chris, you are discussing follow-up and contact with many patients on daily basis from our registry. How often this issue of psychological stress is coming in your conversations with families?
Well, periodically it comes up. I said maybe SADS Foundation might be able to help with that.
Yes.
I would think they would have more people on hand to help.
Yeah,
with that.
but I'm not aware that SADS Foundation has psychologists kind of in the team. As Dr. Sears mentioned, there is issue of state boundaries, yes, which will not allow cross practice, so therefore advice might be given, but not probably
Or maybe they know,
clinical.
right, they may know someone in
Yeah.
that state or
Yeah.
that Canada that might be able to help.
Yeah, they might provide some networking. Yes.
Right,
Good. Any other comments on that topic or different topics?
Yeah, one comment is the fact that long QT is also a disease in which stress and anxiety can lead to arrhythmia. So
Yes.
we
Trigger.
discuss only the aspect of syncope or ICD shock triggering stress, but stress can also induce arrhythmia. We know that most of the cardiac events and the arrhythmic events in long QT1 patient and patient with long QT2 are triggered by acute stress or even exercise. And some focus on the importance of exercise to reduce stress, but some patients with long QT syndrome have a little anxiety about doing exercise because it can induce arrhythmia, which we have shown that it's safe using beta blockers. So all those components should be addressed, like Dr. Aktas mentioned, in a multidisciplinary intervention, not only treating our patient with beta blockers or sympathectomy, which also actually reduces sympathetic activity, but also to address all the components of stress, not only to improve quality of life, but possibly also improve outcomes, reduce arrhythmia. And what we can do, we cannot really have this type of intervention because we're not really, our registry is not focused on that. But if there are any questions from our participants in our registry that can be addressed to us, we can provide more information based on our data. We'll be able to share that, and we can open this line of open discussion with our experts and provide information like we just asked now. If a person feels stressed or a certain day has a question, we can address that. But everybody, I think we should discuss possibly in the future this type of multidisciplinary interventions.
And research about it.
Yeah, we actually had an application recently to the American Heart Association about this stuff.
Yes. Mehmet and David, any other clinical comments on that topic or different topics which we touched on?
Yeah, no, that's a great point that, some of the events that occur, some of the arrhythmias that occur are due to high sympathetic tone, sudden increase in adrenaline. And so there's got to be a balance between trying to reduce the risk of arrhythmia induction, but maintaining a quality of life. And I think that's why having, a multidisciplinary approach. And, we're learning more, right? We were very restrictive in the years past, but we know now that there's room for leniency in certain situations where if your patient is on medications and they've done well, there is room to escalate certain things and I think that comes along with what we're doing here. All the research that's being done here allows us to, think about how to change, certain aspects of these patients' care. So it's, I think, really, really important to continue this.